Director General Army Medical Services, Air Officers, Surgeon Commodores, Brigadiers, Civil Consultants, ladies and gentlemen. Welcome to the fourth lecture in this series of lectures under the auspices of the Director General Medical Services. Professor Walter, who is speaking tonight, commenced his medical studies at the University of Breslau in 1945. But these were interrupted by the war, and in 1946 he entered the University of Würzburg, qualifying in 1950. After serving an internship in the municipal hospital at Essen, he attended the University Medical School at Ann Arbor, Michigan and Columbus, Ohio, as a resident in otolaryngology, passing the American Board's examination in Chicago in 1955. He subsequently returned to Germany, where he was appointed to the municipal hospital at Krefeld, and then opened his own practice in Essen in 1958, and was soon appointed head of the Department of Plastic and Reconstructive Surgery and Otolaryngology at the Heusens Stiftung in Essen, a post he held until 1973. In 1974, he was appointed head of the Clinic of Plastic and Reconstructive Surgery at the Diakonie, Kranken and Stalten, Düsseldorf, Kaiserwerth. Besides being certified as a specialist in otolaryngology in Germany and the United States, he has also become a certified general plastic surgeon in Germany. For the past 10 years, he's been visiting professor in the Department of Otolaryngology at the University of Bonn. He is a registered medical practitioner in Germany, the United States, the United Kingdom, and Switzerland. His international reputation and renown was underlined by an invitation to join the Clinic am Rosenberg in Haydn as chief surgeon in the Department of Plastic and Reconstructive Surgery, a post he has occupied since 1982. The catchment area of this clinic, which, like the Royal Air Force, can be termed as the world. It is true to say that no international forum in reconstructive plastic surgery would be complete without the presence of Professor Walter. He has been much sought after as a speaker at learned societies in many countries in Europe, North and South America, Indonesia, Australia, Egypt, South Africa, and was guest speaker at the Asia Oceanic Conference in Sydney 3 years ago. He is a participant of all international symposia of facial and plastic reconstruction surgery in the United States. He has been guest speaker at the midwinter meeting of the study group in Los Angeles, and instructor and guest lecturer at numerous postgraduate courses in Birmingham, Alabama, organized by the American Academy of Plastic and Reconstructive Surgeons, and has been guest speaker at the medical schools of Miami, Florida, and New York, and at the 50th anniversary of the American Society of Plastic Surgeons. He attends each year as guest lecturer and surgeon at the postgraduate course for soft tissue and facial surgery at the Royal National Throat, Nose and Ear Hospital, Gray's Inn Road, which many of our service ENT surgeons will be familiar and which many have attended. He is, in addition, an honorary member of the section of laryngology of the Royal Society of Medicine and is a Simon lecturer. His main interest is in general plastic surgery, especially aesthetic and reconstructive surgery. He is nevertheless a practicing general ENT surgeon with a particular interest in tracheal reconstruction, bronchoesophagology, and microsurgery. His particular and in many ways unique contribution to reconstructive surgery is in his innovative use of composite flaps, particularly in tracheal reconstruction. His technique for the closure of palatal defects seems not to be associated with continuing tubal dysfunction, a condition which the routine procedures do not seem to benefit. He handles tissue like an artist and displays remarkable insight and awareness of what can and cannot be done with tissue in particular circumstances. He continues to be visiting professor at Bonn, although he is now a resident in Switzerland. He has contributed much to the literature in plastic and reconstructive surgery and has published over 60 articles. He is a member of a large number of learned societies, including the American Academy of Facial, Plastic and Reconstructive Surgeons and the Association of Facial Maxillary Surgeons of France and many others. He is past president of the European Academy of Facial Surgery and a founder member of the Joseph Society. He is in addition an accomplished skier and a linguist, speaking to my knowledge at least 4 languages fluently. So he will accept questions in at least 4 languages. He has been a very good friend to the Royal Air Force since my first meeting with him in the 1970s while serving as a consultant ENT surgeon at RAF Hospital Wegberg. And during my time there, he kindly allowed me to visit his clinic at Düsseldorf. He has operated on a number of service patients and introduced the RAF to the osseous integrated titanium-mounted hearing aids, one of the first of such facilities to be set up in the United Kingdom, and now firmly established at Princess Mary's Royal Air Force Hospital, Halton. He has opened his clinic to the RAF as part of our postgraduate education program for ENT surgeons. Indeed, one of our senior registrars has already spent some time with him at Haydn, and it is our intention that all ENT surgeons in the Royal Air Force will eventually have had the opportunity of working with him in his department. He is a great believer in the bibliography study and in the use of the histological method. As Lowell has observed, the past is a good nurse, particularly for the weanlings of the fold. He holds it important that the minds of students should be trained to look at things from the historical standpoint, echoing Fuller's remark that history maketh a young man to be old, without either wrinkles or grey hairs, conferring on him the experience of age, without either the infirmities or inconveniences thereof. It is therefore with great pleasure that I introduce Professor Claus Walter, whose subject this evening is plastic and reconstructive surgery through the ages. Professor Walter.
Director General, dear Manus, ladies and gentlemen, I consider it a very great honor to be here and to be allowed to speak to such a distinguished audience. And as my friendship brings me back to England and to Great Britain, actually every year, it is a special pleasure to be here tonight. The topic I am talking about will take me through the ages of medical history, and then I would like to point out to you a few of the possibilities which in my field I found useful to use for the benefit of patients who have been mutilated or disfigured either by congenital malformations or due to disease or accidents. I think Manus has said too many kind words for me, and I even remembered all the things which were brought back to my mind again through his kind words. It is believed that plastic surgery was performed in India and Egypt as long as 3,000 years ago. Social pressures for the replacement of the nose seems to have been the initiating factor as a common punishment for certain crimes, particularly for unfaithful wives, was amputation of the nose and sometimes of the ears, a device guaranteed to make a wife permanently unattractive. Similar punishment was meted out to criminals and sexual offenders. It was common practice in prehistoric times for children born with congenital defects of face or body to be killed at birth or left to die. The loss of the nose and the resulting disfigurement resulted in a much diminished social acceptability and, in the case of amputation for crime or misbehavior, total rejection by society. In a historical review of total nasal reconstruction, Larry Nichter and his co-authors noted that the first description of mutilation of the nose came from India, with the deliberate amputation of Lady Surpunaka's nose in 1500 BC by Prince Lakshmana. The mighty king Ravana, angered by this, tasked his physicians with the reconstruction of the lady's nose, and thus commenced the first documented account of nasal reconstructive surgery in India. The nose should also be seen as an organ which lends itself to adornment, and rings and clips are fastened to it even at the present time. In fact, the vogue seems to be undergoing a revival in popularity. Please, the first slide. Nasal disfigurement was also caused by the ravages of endemic diseases like leprosy, smallpox, noma, lupus, and especially the syphilis, which, during the height of the syphilis epidemic in the 17th century in Europe, wreaked such havoc. This was not entirely unexpected, perhaps, when one considers that an estimated 15,000 prostitutes, outnumbering the men by 2 to 1, traveled with the troops of Wallenstein in the siege of Nuremberg in 1632. In India and other parts of the world, people mutilated by disease and having the classical saddle nose deformity were considered outcasts, and even at the present time, though new drugs can cure the disease process, the resulting saddle nose persists. This deformity remains an eloquent hallmark of the disease, identifying the patient and preventing the reacceptance of cured into community. The simple insertion of obturators as intranasal epithesis to build up the nasal bridge was sufficient to enable the victims of disease to be back accepted into their village and social structure. Leonardo da Vinci and Dürer were the first to measure out the face and specified principles of beauty based on exact measurements. If we consider the European head or skull in profile, we observe that when the lines have a tendency to one direction, the appearance are those of the brute. If of the opposite direction, it presents the picture of the classical appearance of the Greek head. The latter was therefore designed to amplify or accentuate those proportions which are characteristic of the human countenance when compared with the lower animals. Charles Bell, the renowned anatomist, in his essays on the anatomy of expression in painting, published in 1806, distinguished between expression in painting and sculpture, the latter which the plastic surgeon must emulate. The painter recalls faithfully the textures of the skin, the various colors, the tortuous veins, and by virtue of this adds dignity to the head. The sculptor, unable to reproduce these aspects, confines himself to highlighting those features which are perceived as indicating a higher form, the antique or we call Roman head. If one compares the skull with the classical sculptured Greek or Roman head, one observes a great breadth in the forehead and the antique more than is natural to the skull. The orbits are larger and the angles formed by the cheekbones of the common skull would be cut off were we to compare the oval to the antique face of the naked bones. The angles of the jaw would likewise be cut off. The first recorded treatment of the injured noses is to be found in the Egyptian Smith papyrus, estimated to have been written about 3000 BC. Hieroglyphics illustrate the treatment of broken noses by nasal splinting and external adhesive plaster. The first really detailed description, however, was by Sushruta Samhiya about 600 BC. His description of the nasal reconstruction technique, which was not the Indian forehead method, which is commonly attributed to him, but one based on the use of a cheek flap. This represents the first description of the use of a pedicle flap. The Roman physician Celsus was the first European to record techniques of closing defects of the nose, lips, and ears by using adjacent tissue. It is worthy to note that Avicenna around 1000 AD, in his Canon of Medicine, highlights the importance of making incisions properly placed to avoid cutting through muscles of mimic expression, severing nerves which later could cause numbness of skin areas, and using various drugs of staunching the blood, plasters to allay the pain, and the appropriate instruments handy. From the facial plastic surgeon's point of view, the proper choice and selection of incisions within the skin creases lines is still of great importance. These developments and documented reports almost certainly provided the impetus for similar work in other countries. Thus, when in the 15th century the Branca brothers became celebrated for their surgical abilities in the art of total nasal reconstruction, it is not surprising that their techniques duplicated those described by Sushruta Samhita some 2,000 years earlier. In 1430 AD, Antonius Branca from Sicily, influenced by his father's work, developed a new technique for total nasal reconstruction using a flap of tissue taken from the arm. This method was practiced and kept alive mainly through members of a family in Calabria who specialized in reconstructing noses, lips, and ears. It is from this family that Gaspare Tagliacozzi of Bologna learned and popularized the procedure that came to be known as the Italian method. This involved a lengthy and tedious operation series consisting of 6 separate steps. So great was the renown of Tagliacozzi that shortly after his death the magistrates of Bologna honored his memory with a statue which represented him holding in his hand a nose. But later, after his death, theologians attacked him for impiously interfering with the handiwork of God. His body was thus exhumed from the consecrated ground of the church of San Giovanni Battista, and his work was neglected. It was largely forgotten except for the comments emanating from Paolo Zacchias, physician to the Pope Innocent X, who 1612 summarized the effects Tagliacozzi had during his lifetime. If a malefactor was condemned to lose his nose and thereby lost it, it was legal to have it restored by the operation of Tagliacozzi, because the operation could be considered a punishment on account of the time required to perform and the pain endured. This is a good example of the deviousness of theological arguments. The sympathetic theory was popular in Tagliacozzi's time. It was believed that tissue removed from an individual would thrive in a recipient while the donor continued to live. The death of the donor, however, would cause the graft to perish. This, together with the fact that grafts were borrowed from a servant, prompted the following satirical lines: "So learned Tagliacozzi from the bony part of Portras's bum." Tagliacozzi's work was successful enough to remain in popular use until World War I. It was published 1597, 2 years before his death at the age of 54. About the same time, Pfalz point was achieving prominence in Germany. Heterogenic free grafts were unsuccessfully tried, as well as alloplastic materials. Tycho Brahe, the astronomer, wore a golden nose after he lost his own in a duel, perhaps a mute comment on his perception of the state of the art of nasal reconstruction at that time. Lisfranc represented in 1828 his technique of nasal reconstruction using a forehead arm flap. In his paper presented at the French Academy, he explained that he used a piece of cardboard to take measurements of the new nose. He also knew exactly how to cut the forehead flap, taking care to incorporate some nourishing vessels for its survival. It was well aware of the fact that in nasal reconstruction at least 1 week or more was required before the nutritional pedicle could be separated. Felpo, 1795 to 1867, stated that the operation of nasal reconstruction, the object of which was to repair mutilations, constituted, when successful, one of the greatest triumphs in surgery. Later on, Roux Dupuytren came to occupy the sublime heights of the plastic surgery mountain. The actual idea of folding a forehead flap for the restoration of the lower part of the nose belongs to Auguste Labat of Paris, who suggested this method in 1834. In 1835, Delpech from Montpellier used and employed a folded thin flap for the use of the reconstruction of eyelids and lips. Another example how to approach the ethmoids. It was a very simple way and very gave clear visibility. Karl Ferdinand von Graefe was the foremost German surgeon in the 19th century who lived from 1787 to 1840. He entered medical school in Dresden. In 1810, at the age of 23, he was promoted to professor of surgery and medicine at the University of Berlin. During the war against Napoleon, he was called upon to perform in excess of 50 amputations a day. And moved by such mutilating procedures, he devoted more and more of his time to study of plastic surgical techniques. He was a linguist of note, speaking 7 languages, and traveled widely, visiting both France and England, where he was very well received. He commenced transplantations in Germany when everybody thought it was totally impossible. He introduced the Indian and Tagliacozzi's method of nasal reconstruction in Germany in 1817 and was the first to introduce the term rhinoplasty into the literature. In 1836, the term plastic surgery was introduced by Zeiss in his Handbuch der plastischen Chirurgie. Johann Friedrich Diefenbach, in 1792 to 1847, was a general practitioner in Berlin until, as a result of his contributions to plastic surgical techniques, he was promoted and given the title professor in 1832. Among his many contributions to plastic surgical technique should be mentioned his work on lip and cheek reconstruction. He then went to earn the title Father of Plastic Surgery. He described the reconstruction of a mutilated nose from the remnants by pulling pieces back together. He used very little ligatures, but more pressure and cooling to stop the bleeding. He was the first to postulate that the plastic surgeon should behave like a sculptor. His operative record is quite astounding, and he is reported to have operated on 120 torticollis, more than 1,000 hair lips, and over 200 nasal reconstructions. In an age when antibiotics were unknown, his figure of 5% death from infection is eloquent of a superb surgical technique. He also used ether as an anesthetic. A copper etching by Wales, just a few examples of old publications. Made in 1794, shows the procedure used by an Indian surgeon serving with the British forces in reconstructing the nose of a shepherd who had been taken prisoner by the Sultan Shabib Tibu, who had ordered the cutting off of his nose and one hand with the view of intimidating the British troops. How far he succeeded in this regard is not recorded. It was Carpew who in 1816 introduced the operation of rhinoplasty to England. Carpew's work, however, was not developed, and British surgery missed the opportunity of advancing the work that he started. A study of the bibliography shows that British surgeons displayed little interest in plastic surgery at that time. However, when European modifications and improvements in rhinoplasty techniques had been passed back to India, Brett was able to quote Graefe, Diefenbach, and Liston. Liston's first rhinoplasty employing the forehead Indian rhinoplasty technique was performed in 1827, but it was not until 1837 that Warren performed the operation in North America. Adams, in 1875, published his report on the treatment of broken noses using special forces and external fixation. Koenig, in 1886, used bone from the forehead in the treatment of saddle nose and composite grafts. Just a few examples. Lawson, in 1884, treated septal deviations and deviated bones with an apparatus which he applied external pressure to the nose. This former treatment was mistakenly attributed to Jacques Joseph. One often reads in the literature Jacques Joseph referred to as the father of aesthetic rhinoplasty. In the interest of historical accuracy, I must contest this claim. Despite Joseph's many admirable contributions to the field of rhinoplasty and other aspects of plastic and reconstructive surgery, which should not and cannot be ignored, the age of corrective aesthetic rhinoplasty actually began in 1887 when John Orlando Rowe, 1848 to 1915, an otolaryngologist from Rochester, New York, described an essentially intranasal operation confined to the tip of the nose and its entire skeletal aspects. Just a few slides to show you the different techniques which were published and used in defect surgery and in reconstructive procedures, giving you some idea of the manifold possibilities and ideas our surgical forefathers had. Quite ingenious operations and incision lines were invented and used and are being used still in some way today. Lexa was another very famous surgeon to devote part of his work to plastic and reconstructive surgery. In 1887, Rowe published a paper outlining the advantages of approaching nasal deformities intranasally rather than extranasally, thus avoiding unpleasant external scarring. Rowe's publication in 1891 of the correction of angular deformities of the nose by subcutaneous operations was another first in which he described corrective rhinoplasty of the entire nasal profile, where the nose was reduced in size and protrusion by intranasal removal of the prominent hump. Rowe's paper of 1891 was the first to incorporate before and after photographs of 3 patients with successful intranasal operations. Joseph's first photographs of 2 cases appeared 1 year later. This is Joseph in his operating theater in Berlin. He was originally an orthopedic surgeon who later became a plastic head and neck surgeon, as well as, of course, body plastic surgeon. It is interesting to note that Joseph made no mention of Rowe's articles, even though all the medical reports at that time were published in the Index Medicus.
Perhaps it might have hurt his ego, since he also did not mention Weir and his first attempts at corrective rhinoplasties with semilunar excisions of skin on the ala to reduce the width of the nostrils. However, it cannot be denied that Joseph was the first to develop a general concept of facial corrective surgery and reconstructive procedures, and he should be called the true father of aesthetic and reconstructive facial surgery. Rowe's exceptional aesthetic sense is revealed in a statement he made in 1905. In the correction of all facial defects, the surgeon must not only be an artist but also more or less of a sculptor with perception of symmetry as related to the different features, echoing the principles as outlined by Bell in his essays. He was also the first to appreciate the importance of the psychological aspects of plastic surgery, which he so cogently expressed in a paper in 1905, in which he states, "The effects upon the mind of such persons with physical defects is readily seen, reflected in the mental attitude, and leads after time to a permanent distortion of the countenance. It would be reasonable, therefore, for any physician who considers the subject to postulate that many potentially brilliant lives would be noble personalities, and much latent talent will have been lost to the society by reason of embarrassment and mortification arising from the conscious or, in some cases, unconscious influence of some physical infirmity, deformity, or unsightly blemish." Reading this, one instantly recalls the verse from Gray's Elegy written in a country's churchyard, which embodies a similar thought. Some mute, inglorious Milton may here he rest, some crumble, guiltless of his country's blood. The first nasal infracture was described by Weir of New York in 1892. He introduced a platinum prosthesis and celluloid obturators to replace deficient cartilage, and he was the first to excise a wedge of shaped pieces of cartilage and mucosa from the caudal septum to correct the hanging tip. Mangold was the first to use a rib cartilage to correct saddle nose deformities in 1900. This, ladies and gentlemen, brings me back to the first chapter of my presentation, in which I just wanted to give you a historical review of the different possibilities and to show you what our ancestors had dreamt and succeeded to achieve. Here, out of Joseph's book, maybe we could focus the left a little better. His first attempts in the 20th, when the book was published, in auricular reconstructions, in large chest flap turnings, similar to the Beckham flap. So actually it should be contributed to Joseph in defect surgery. And he was also the first one to have a concept of aesthetic surgery in tightening up facial skin. That sometimes the patients worry that things go too far is expressed in this little paper. But unfortunately, ladies and gentlemen, we don't have reached that stage. And that might be just a dream for the future to come. Now, I would like to take the opportunity to show you now a few clinical cases just to show you and indicate to you some of the principles and possibilities
in facial plastic and reconstructive surgery. When dealing with the face, you should know and remember that the face has certain compartments which by flaps should only seldom or with great proportions be bridged. For instance, skin grafts should never bridge these compartments because they invariably will contract and become very unsightly. We start with corrections of proportions of the face like Dürer and Leonardo da Vinci have explained. So this is the first aspect of using and advancing and altering the proportions of the face, the so-called profile plasty, which become a greater and greater role in the aesthetic field of surgery, rhinoplasties and facial corrections at the same time. I'd like to start to show you a few examples with the hair transplant. We can have free grafts or flap coverage, like here. And from here we proceed and come to that point. Of course, you can use nowadays some tissue expander also, but not often or not in all cases this is necessary. From here we move to the ears, and I personally prefer to use autogenous material in conjunction with flaps and free grafts to reconstruct ears. We use composite grafts to outline the helix rim and try to achieve as much a normal ear as possible. Another example of a total auricular reconstruction. And that leads me to other possibilities and new horizons using the titanium osseo-integrated implants. For instance, in a case like this, who had an operation elsewhere before and he was sick, was going through all the trouble of the procedure, or this, as it was invented to attach the epithesis to the ear, was quite embarrassing, either when you went to bed or swimming and you had to take off your glasses. Therefore, the incorporation of screws which come through the skin over bridges, then mount your epithesis. Here the titanium screws are inserted, covered with a split skin graft. Then the ear is measured to its proper size in relation to the other ear. Impressions are taken, and this is the back portion of the epithesis, which is clipped to the metal bar between the abutments, and it saves the patient quite a number of surgical operations. You see another example. And a patient who had this epithesis fitted, it's very difficult to distinguish this from the normal ear. So there are some possibilities to relieve the patient of some of the operative problems and pains he has to undergo. This gentleman was very much troubled by the aftermath of a cancer resection because his wife's, he came from one of the Middle East countries, would not take too much of a liking for him any longer. And the first, we tried for fun, just the first intubation through the maxilla. Now first we had to diminish the size and close the orbit
in order to fasten some osseointegrated bridge to enable him to wear a prosthesis. Here I used a temporalis muscle flap in conjunction with the forehead scalp flap to close his defect. Here are first abutments. Then I reconstructed his eyebrow. This is the epithesis, which was fitted. And then he went back home. Another possibility to reconstruct the ear in severe congenital malformations we found very useful in conjunction with a total facial rehabilitation in Treacher-Collins malformation. I advanced the mandible, altered the shape of the eyelids, and we came from here to that. Nasal reconstruction is done by several different flaps. Maybe we could focus this a bit. And first, the most common operation for aesthetic and functional reasons, the rhinoplasty, shows you all the manifold possibilities of shaping and altering cartilages and bone. Here's two examples to explain that, or for cosmetic reasons to alter nasal deformities. Now, I would like to show just briefly the possibilities of hair lip nose corrections, and more problematic are the secondary revisions. And I must say a little word against the open rhinoplasty, which I found not always very useful and to the benefit of the patient, though the surgeon might temporarily see a little better. With an increasing number of patients being operated the open way, there will be invariably more deformities on the columella, and in my opinion, it limits your possibilities to, you see he had this cut before, in the all-over approach to a good reconstruction, when you have to insert grafts, etc. This is a little more problematic, and we used a composite graft from the anterior conchal aspect to give him a more normal looking nose and an open airway. Another possibility to the nasal reconstruction, the severe middle face fractures in which we had to build up the nose, build up the middle face, and came to that appearance. In some cases, I use Gore-Tex as an implant and hydroxyl apatite to fill out facial bony contours. Nasal reconstructions in certain limited areas are benefited by the free transfer of composite graft. You can cut from different areas of the ear, and fortunately we have two to resort many times to two donor areas. You can relieve and correct endonasal strictures as well as external deformities. Here you see an example of the use of composite graft to reconstruct the nasal tip. And another multitude of operations preceding the rehabilitation by correcting the ears, building up the mid-face, the palate, and the nose. She later on became a nurse. Another principle, and you cannot or you should not always and alone use a forehead flap for external coverage. I found very useful in endonasal strictures and reconstructions to use a forehead flap which is turned down this way after de-epithelialization for certain areas in the nose to prevent cholesteatoma formations. This is a method to lengthen the deformed and nasal defect by turning down nasal skin and using a forehead flap. This is the converse method of scalp advancement. Or the use of an oblique forehead flap, like in this case, where he had an accident due to an electrical burn, where I used this. And of course, during the stages of reconstruction, it's always sometimes difficult to keep the patients in a good mood because they never know what to expect. A visor flap for total midfacial reconstruction after excision of basal cell carcinomas in this region. Now, may I have the second tray, please? Oh, I'm sorry. And tissue expansion and keloid formation are sometimes used for adornment and other times just made to trouble the surgeon. But we have in skin surgery to adhere to certain principles which were brought to us by our forefathers. And just to show you a few examples of the principles used, could we maybe just focus this a little better? These are the main workhorses: tissue advancement, the VY advancement, the rotation transposition flap, bipedical flaps, and Z-plasties. And if we adhere to those principles, I think we can handle almost everything. Z-plasty is a very useful method of tissue transformation, but you should always try to break up certain scar lines to eliminate a straight scar, which is more readily visible. Just an example, and if you even have a severe injury, keep every little skin piece, save it, and use 7/0 nylon to, after careful subcutaneous closure, to eliminate a straight line of scars. Maybe we focus this a bit. Again here, you break up, even by wider undermining, certain scar areas, and I'll come to that a little later. And sometimes in scar revisions, which are the sequelae of trauma, you can dermabrate the scarred areas and excise part of the scar and then close the wound This will give you a much better scar and less visibility. Break up the line again. Just a few examples. And this patient shows me and gives some to discuss and talk about. When you have the aftermath of severe injury, you see these trapdoor deformities, thickening of the scar. There's one thing to learn from these. If you have a trapdoor injury and accidentally she had no upper lid here, maybe we could focus that a little better, please. That was all gone. You must undermine the corresponding area even farther than the injury goes. This will divide the subcutaneous tension and eliminate from the first moment on any thickening of in the post-operative wound healing, in the post-wound healing time. Now you see here the same, where the surgeons were not aware of these principles and didn't apply them. So in the reconstruction also, if you want to diminish this, you have to undermine all the way around on the opposite, not injured side. And here I reconstructed her lid first. Never use full thickness skin for lid reconstructions. Always so 3/4, not very thin grafts because they will retract too. And sometimes I freshen the edge of the lid margins, close it to leave the lid closed in upper lid reconstruction for several months sometimes. Then you see all the scar tissue here, so I simply excised that and went ahead and undermined the rest. I broke up the scar line here. And that was her in an intermediate stage, with the lid still a little lacking the function. And when she had reached that stage, she said to me, "Oh, I'd like just to have a rhinoplasty too. The nose has always been too big for me." So after doing this, before the rhinoplasty, you see, she looked like that. And another example of a wide scar where we reduce the scar by undermining, and we call it serial excisions. You excise part of the scar, advance the skin, and excise again. Breaking up the scar line again. And in the after treatment of burned wounds, or in cases where patients tend to form more keloid or scar hypertrophies, I advise that for many months, patient should wear these compression bandages. Principle of the Z-plasty, which is useful, but you can only use a Z-plasty where you can borrow from other portions of the skin. If you don't have skin enough to borrow from here, you cannot properly execute the Z-plasty. So you must keep that in mind. Principle of the Z-plasty showed on this excision of a hairy nevus. And always remember, you should place your incision into the relaxed skin tension lines, and sometimes pays to have a little drawing of that ready in the OR to always look back where these lines lie. In lip reconstruction, you can use the Abbé or Estlander flap, but remember, again, it proved to me to incorporate and de-epithelialize part of it to fill up subcutaneous tissue defects. severe contraction after partial loss of the lower lip, and we used again several advancement flaps. Sometimes if you have superficial scars which are somewhat retracted and below the level of the skin, you can use the scratching technique, and by doing these little superficial incisions you actually create little Z-plasties, and the scar contraction will bring the scar up to the normal level of the skin. Freezing treatment or injection of cortisone are methods to use in order to overcome the tendency to form scar hypertrophies in addition to the compression bandages. Single unilobe or bilobe flaps are used. And here a combination, and that shows you that when you have the skin area in the neck, you should not, or at least not forever, leave skin grafting as it is, but try to get rid of the skin contraction by breaking up these scar bands or using additional flaps. This dermatome I found better to use to incorporate in some of the full thickness skin a little layer of fat, and it will give you a much better appearance of the skin-free flap than just to go and use the ordinary Wolf-Krause flap. This instrument is nice to secure large amount of skin, but you have to have certain body areas which are amenable to that. And of course, in this last resort, you have the net skin transplants. Here in that case, just we used, and we come to that later, a myocutaneous flap in this patient and a shoulder flap to get rid of his neck contractures. The principle of a facelift used can be helpful if you have facial scars in the center portion of the face. You just use a reverse facelift to pull the skin forward and not sideways. Island flaps are useful to cover defects of distance areas. And here this little boy was treated by two large flaps advanced from the chest upward. And then all these patients should be kept in stretchers to prevent cicatricial bending of parts of the body for months to come. Now this is an interesting case which shows you steps of the reconstruction. She came to me in this stage, severely mutilated lip and jaw, partial bone loss, and first we build up the mandible with bone grafts, then we revised part of the scar, then I inserted osseointegrated implants in the newly and reconstructed mandible. She was fitted with dentures and came out like that, with full functioning of her lower and upper lip. Severe injury, again treated in the same way I told you, skin graft, orbital and lid reconstruction. And this brings me to the technique, just a brief survey of the methods of lid reconstruction, in which I use quite often mucosa and cartilage from the nasal septum. And this avoids taking other parts of the lid of the corresponding side, mutilating that also. So here we have the reconstruction of a defect of the lower lid with this composite graft from the nose. Another example of using the forehead skin, and you see grafts in nasal reconstruction in such a way, thin grafts will always tend to contract and cause more problems. That was a patient who had 5 operations before, after he had lost his nose in a motorcycle accident. So here you see his picture: ptosis, severe nasal deformity, impairment of breathing, and this was, unfortunately, I mixed up the pre and post-op. Here you see he has a full functioning lid, and that was the way he looked from the side before I started. Another example shows, I got this patient's pictures from the clinic who treated her first. And you see, they did not take into account all the principles which I just briefly explained. They just sutured this together. They did not reconstruct her mid-canthal area. And when she came to me, she presented that picture. You see the trapdoor deformities not corrected, and a total obliteration of the mesial canthal area and an obliteration of the tear duct system. So I have invented a new operation to reconstruct tear ducts using a flap of mucosa and cartilage from the septum, and I used it in her case, and this is a possibility to use that too in cancer surgery when you want to keep a drainage from the orbit where you have taken the total mid-canthal area. This is the flap. The turning point is up here at the cribriform plate and the perpendicular plate, where this flap, composite flap, is pulled through. You make an incision at the inner canthus, do an endonasal ethmoidectomy, create a big channel between the caruncula and the nasal opening. And here you see the flap is being brought up, and it never collapses because of the cartilage structure underneath. Here's the mucosal part, and here you see the cartilaginous portion coming or being brought up, and this is her afterwards. She could and used to wear for a few months this little drainage tube. Total lid reconstruction by cheek advancement. And another possibility to use a distant island flap when you have a large tumor on the nose, based on the temporal artery and vein. Now, this patient came to me after 10 operations, adding always, maybe you can focus the left screen a little better, little free grafts, not achieving anything. So I resorted to a big shoulder flap with which I could obtain enough skin and subcutaneous tissue to do everything. Again, you have to envisage the final outcome. We use some hair transplants here to give him an eyebrow. Even in children, a little defect like this is not so easy. You have to use flaps in order to prevent contractions on the lip. Large cancer cases, and now we come to lip reconstructions, can be used And I always try to incorporate in my reconstruction skin flaps which are supplied by branches of the facial nerve to retain function and appearance. This is an interesting case. She came to me referred from another physician because she underwent some orthopedic treatment. He said, "Oh, I have this little bump here for many years." And I looked at it and I said, "It doesn't seem to be just like a little bump." And when we finally ended up a multi-stage excision, we found basal cell carcinoma all around. So I ended up with this picture. You see a huge defect intraorally and externally. So in order to reconstruct this in one setting, I used this portion of the lip to bring down mucosal part to close the opening. I used this portion to bring down and narrow the gap, and I used adjacent flaps in the total closure. See, this was before the final excision was done and histologically examined. This was turned down inside. Here I closed the oral opening. And this is her recently. Large cheek advancement for cancer treatment, combined with full thickness skin grafts. And facial nerve palsies corrected with temporalis and masseter muscle flaps and tendon grafts. Large defect of forehead, eye, and skin. And now, the latest development, except and apart from the free tissue transfer, are the muscular cutaneous flaps, which are very useful and excellent methods to bring bulk, muscle, and a very assured blood supply to other areas of the body. And I like, based on Joseph's publication, I'd like to show you, as the last case, one patient in whom I treated and who was treated by a combination of methods. She had this huge carcinoma of the maxillary antrum. It finally extended even more, and when this picture was taken, I had to remove more here and more here. Actually, I had to excise almost the entire mandible. Then I used this myocutaneous chest flap on her to bring up and fill up the lower portion of the cheek. And then I was aware that her frontal skin was still innervated by the facial nerve, and so I used her facial frontal skin, dissected the facial nerve, and brought it down as a cover for the cheek. Here you see the huge, enormous defect. She wears these little parts, and they are put together like a puzzle, and with that in place, she is able to speak and eat without any problems and speak very clearly. And finally, to show you her fitted with the plate and the dentures, you see everything is covered, and here you see the cheek, the forehead flap, and it has retained its function. we will have to do a little bit more on the lower lid too. Ladies, please light. I think if we look back through history, we should be very grateful to our forefathers who have done the original work, have given us a lot of ideas, and I'm sure, based on past history, the young generation to come will find many new ideas as far as free tissue transfers and what might not come for the benefit of the patient in treatments of facial plastic reconstruction to cover defects. Thank you for your attention.
You are prepared to answer questions?
Yes.
Professor Walter will be only too happy to answer any questions. I think there's something for everybody here: oral surgeons, ophthalmic surgeons, ENT surgeons, general surgeons, and those just who are curious. Well, can I start off? I've written a few little things here just to carry on the historical element of your paper there. I was interested in tissue expanders. You didn't.
Yes, I didn't mention that. I was afraid I would
to speak over here
go over time too much if I went into that too. Of course, the most natural tissue expander is the pregnancy. And based on that principle, Neumann and Radovan later on invented the method to insert balloons, silicone balloons, underneath the skin, which can be expanded and filled up with saline, and over a period of weeks, by every weekly filling with 30-40 cc's, you can expand and actually create an artificial pregnancy under any portion of the body. And that means you can have nowadays little tissue expanders for facial treatment and gaining of facial skin. You use that in breast reconstructions, in burn cases, to gain enough normal tissue to overcome the scar which you excise afterwards. But it is a long drawn procedure, and not many patients accept the fact that they have to run around for many months with bumps on the head and on the body, which are only too clearly visible. There are new ways of rapid tissue expansion where you keep the patient in the hospital for a week and add a continuous fluid drop. But you must be very careful. If you overextend the skin, it will become necrotic. And there's always the danger that suddenly, with one of the fillings along the way, you create an infection, or infection settles in, and then the whole thing is gone because you have to take it out immediately. And then you have to start all over again. And some patients accept it, some others say, aren't there other ways of doing things? But this is a new additive which, with the different shapes and designs of these tissue expanders, has, of course, a great future.
Is there a mitotic activity here, or is it just?
They have checked it histologically whether there's just an enlargement of the cells or a mitotic activity, but so far they have not come to any conclusion. And I'm not prepared to answer that question either. I don't know.
Was that Mohs technique you were using on a couple of excisions there of basal cell count?
Yes, we do all the controlled excision, and then after all is clear, then we start the reconstruction.
And what sort of cure rates do you get using that procedure compared with other?
Oh, it is by far better. Only except for those sclerotic basal cell lesions which spread underneath the skin and are very unpredictable. Sometimes you have the lesion here excised and it springs up here. So that type.
It is in relation to embryonic plates.
I don't know, maybe so.
And I think no dermatologist has given full explanation why these certain, only special sclerotic basal cell carcinomas do that. The others you can fairly well control by assured excision and free tissue margins.
And you have obviously the frozen section technique.
We can, yes, we bring that immediately to the pathologist and get the answers.
Now, people perhaps have now caught their breath and might like to ask questions. Here we are. Charles.
First of all, thank you for
Charles, would you speak into the microphone so we can record you?
Yes, thank you for a very interesting presentation, an immense experience. I was interested in your osseo-integrated implants and your views on the use of those implants in irradiated bone, so ear, nose, orbit. Have you had problems in those areas when the patient's fully irradiated?
I don't have so much experience with these irradiated bone areas, but from what I've heard from Bronnemark, who invented this system, they tried, and I think if the bone is blood supplied, you should not have any problems. The only question is, you see, where the bone is brittle and too much damaged by the irradiation, then it might become a problem. But the problem is to prevent infection, and you should make, and this is the catch, if you are able to put a very thin skin graft on top of the periosteum of that bone, then you can put the abutment through the skin. If you need a big bulk of skin to protect your bone, and you're afraid that the bone with this thin cover would not survive or live or be sufficiently nourished by the periosteum, then you shouldn't do it, because this is a source of infection and the entrance through thicker and more with sebaceous glands and sweat glands skin. So I think you have to have a very thin cover over the periosteum to make the system work. If the skin is thicker, then you run into problems of local infections. And with irradiated bone or other structures, this would be deadly.
Professor, in view of the current interest in this country in surgery before birth, when do you feel is the optimum time to close primary closure of a cleft lip? When do you close them?
I close the lip and reform the base or the floor of the nose in the first, let's say, 3 to 6 months. And then I have used, or I have invented, a method of a double Z-plasty closing the soft palate. And I do that at the age of 2. And then I personally feel that at the age of 4 or 5, you can close the hard palate, but while that goes on, these children wear little mini plates. And I personally feel that secondary revisions should not be carried out too early, because you might damage some growth areas and centers and have to pay for the damage later on, or rather not you, but the patient. And so I feel I can do safely secondary revisions if they are not so mutilated that they can't breathe, or the deformity is so outrageous that you have to do something. But comfortably at the age of 15, 16, 17. And some people try and start to operate nasal tips at the age of 10 or 11 or 12, but I don't know how they look in 10 years. So I would be very cautious, because actually what you gain or you do it for the sake of the parents. I mean, the child can go for 2 or 3 more years without too much harm. If you're sure, then you can do for the next 30, 50 or 70 years much better job and eliminate the necessity perhaps to go back again 1 or twice.
Professor, what methods do you use for reconstructing the mandible if the patients had radiotherapy?
You see, you can use partly, I would say, the most proper method now, if you have all the equipment, would be a free graft from the iliac crest with a free tissue transfer and microvascular anastomosis. But in order to do that, and this is the reason why I didn't mention it, because right now where I live, I don't have the facilities. But if you start that, you have to have 2 teams ready to go anytime, day or night, because once you see that the flap turns white, you have to be in within the next half hour to open up everything. And that means you have to have a team of surgeons and nurses ready to be present and ready to go within half an hour. And unless you have not these facilities, you should never start, because the procedure is not so difficult. You just cut out the pre-outlined piece of skin and muscle and hook it up to certain arteries and veins. This is just a tedious sewing job, with or without the bone in it. But the problem starts afterwards, the aftercare. And sometimes they just become thrombosed, and then you have to open up everything, wash out everything, and then you start suturing back. And sometimes, if you have tissue defects also, you use a large myocutaneous flap, including some rib bone. You can use that. Or what is lately done also, you use the ends of the mandible, if they are, and when they are present, take a large heavy bar across to resemble the mandible, and suture or screw to it some aluminum oxide implant. There's some new material out, just like the hydroxyl apatite, which is very well tolerated by the body, and it becomes incorporated almost, and people go with that for years without any problem, and then you can later on add some bone or take partial sections to rebuild the mandible. Or these preformed titanium total mandibles filled with spongiosa bone. So there are several methods, but just according to the case, you should make your selection of the procedure.
What about outer table skull bone? Is that a useful thing in that particular position?
I don't know. I only know that it's, you can use it for nasal salinose corrections. How it works on the mandible, I don't know. Or orbital reconstruction like that. But for the mandible, I've not heard, and I personally have not used it.
I was interested in the use of pressure bandages to prevent keloid formation. How long do you leave these on, and what sort of success rate do you get with them?
It is quite amazing, the success rate, if you have the patients wear these masks day and night for over a year. If you just leave it on for 2-3 weeks, it's not doing any good. They have to wear it at least for month and month.
And do you find many patients will tolerate that?
Some are sensible enough to do it, some others don't, so you just have to tell them this is the way to treat you. If you don't accept it, you have to see what you look like afterwards. But this is actually the only way to, in conjunction with occasional cortisone injections or freezing, to cut down and really soften up these. And they do these ointment massages when they take off that to wash, and then they rub it for twice or three times a day. They have to massage with certain ointments to soften up the tissue.
If you operated on a Negro, would you suggest to them that they should wear a mask for this length of time?
Unfortunately, I don't have had so many. But if you do any elective surgery and you know of that, and especially in that race, you should tell the patients that they might have to expect trouble afterwards. But how well you can apply it to a facelift scar or just a simple scar on the face, a total pressure bandage, I'm not so sure that you can ask him to wear that for a month if he says it's just a little scar.
Yes, post-kinoplasty keloid can be a most embarrassing.
Yes.
And grows to enormous size.
Yeah, a friend of mine, Otto Steindl, has more experience, and he claims that by excising the keloid and then using a full thickness skin graft, he almost cures them. But I think you have to use a rather large piece and actually pull the ear forward and suture to it to eliminate any kind of tension on the operated area, and maybe that helps.
Is tension part of the development of the ear?
I don't know, maybe just a little tension to pull the ear back might be an initiating factor. I don't know, it could be, because he claims if he puts the ear forward, puts in a large graft after the keloid excision, he can cure them.
I think we have had more than our penny's worth this evening. Director General would like to say a few words.
Ladies and gentlemen, it's given us most great pleasure to host Professor Claus Walter here at Halton tonight, and to listen to this, the first of the prestigious lectures which the Dean has arranged for us this year. It's also been a great honour to have such an eminent and a world-renowned expert as Professor Walter speaking on a subject which is both of clinical interest to us and of specific relevance to us in the military. Now, it is a happy coincidence that Professor Walter should be discussing aesthetic surgery on St. Valentine's Day. However, it's particularly pertinent that he should have been talking on this topic at the present time. As you all know, the Surgeon General's review of service hospitals is shortly to be extended, and we anxiously await the outcome, especially in respect of the hospital here at Halton, the seat of our plastic surgery and our other special units. We're acutely aware that although the primary role of the hospitals is to train for the treatment of war wounded, the expectation of conflict appears to be receding by the minute, both in reality on the Central Front and in the mind of the mass media from everywhere else as well. Nevertheless, whilst congratulating Professor Walter on the hope which current events raises for his homeland, we must acknowledge that the pressure for a reduction in the medical services and the service hospitals in particular will increase, and that some of this pressure is likely to be directed at elitist practices such as plastic surgery or even oncology. I make no predictions on this score, and you must read nothing into the use of these particular examples, but it is nevertheless imperative that we continually remind our masters of two fundamental truths. Firstly, that the skills thus learned, or indeed the practices themselves, are necessary for the treatment of casualties. And secondly, that without the facility for certain of our members to practice in such fields, the medical services will become professionally dull and will wither on the vine. Thus it's essential that we do not lose sight of our role and that we take every opportunity to expand our knowledge and our interest in those specialist areas of medicine which could have a bearing on the treatment of military patients. And tonight's lecture, sir, has been a classic. The subject was relevant, especially its historical and its military references. The facts were elegantly presented and beautifully illustrated, and the lecture was most eloquently delivered in the most fluent English. We congratulate you, sir, on your superb presentation, and we thank you most sincerely for sparing this time whilst in this country for a short while to educate, to enthuse, and to entertain us so admirably tonight. Thank you very much indeed, sir.